Hi, Mike Gibson and my good friend and colleague, Danielle Belardo, obesity and prevention expert from LA. Danielle, welcome.
Hi, so glad to be here and chat with you today.
Well, we have a lot to talk about. First, let's kick off with one of the studies from ACC, the PRAGUE study comparing weight management to ablation. Danielle, what were your thoughts about this study?
Yeah, so I thought it was a great topic, and I think it was really exciting for everyone in ACC to get to see the results. So, Prague 25 trial, this essentially looked at lifestyle modification plus antiarrhythmic drugs versus catheter ablation for atrial fibrillation treatment in obese patients. So essentially, obesity increases the risk of atrial fibrillation by 19 to 29% for every 5-unit increase in BMI. And we've known for a while that obesity is a risk factor for atrial fibrillation. And while catheter ablation has been more effective than antiarrhythmic drugs, the impact of lifestyle changes combined with antiarrhythmics hadn't been thoroughly tested against catheter ablation. So, what this trial did was they compared catheter ablation to lifestyle modification, including weight loss, combined with AADs, which is the antiarrhythmic drugs, in obese patients with AF. And at 12 months, freedom from AF was significantly higher with catheter ablation, about 73%, than with lifestyle changes plus antiarrhythmic drugs, which is about 34.6%. And so, the headline and a lot of the headlines that you're seeing about this is that, lifestyle change doesn't make a huge difference for atrial fibrillation burden. And it's kind of giving a misread on actually what we really know based on the trial, because the trial's goal was to reach greater than 10% weight loss in the lifestyle group, and only 5.8% of weight loss was achieved at 12 months. The legacy trial, actually, this led to greater than 10% weight loss, and they found 45% AF freedom without AEDs or ablation. Prague didn't meet that even endpoint, that 10% endpoint. And the participants, they remained in the subtherapeutic range of weight reduction with only a modest improvement in their VO2 max. And so the lifestyle changes that can have that impact on atrial remodeling, we didn't get to see a true value there because we didn't reach it, which is quite common with intensive lifestyle intervention trials. And I just wanted to compare this to, one thing that the Prague investigators acknowledged themselves in the limitations, which I think was great. They said planned weight loss of greater than 10% body weight was not achieved, and GLP-1 agonists were not systematically used, which I think is a fair, thing to add in there, because if you compare this to, for example, SURMOUNT trial for tirzepatide, this has really redefined what's possible with pharmacological weight loss plus lifestyle intervention. Keep in mind, all of the GLP-1 trials include a lifestyle diet and exercise information as well. And for SURMOUNT at 104 weeks, the extended data showed up to 26% total body weight reduction. That's nearly 5 times more than Prague. And so I think the question now is, in the era of GLP-1 receptor agonists being so incredibly effective to help our patients make those dietary and lifestyle change to achieve a lot of remission, whether it be of prediabetes or hypertension or other ASCVD and AFib risk factors, even sleep apnea improvement. I'm curious where these will work into the equation with studies looking at atrial fibrillation burden down the road.
And also, it teed it up as competing strategies rather than complementary strategies. And so maybe for the next go round, they should combine the two as one of the arms.
Absolutely. Yeah. And that's the thing, is that I think people think it's a binary. They think, when people are on a GLP-1, it's just the medication versus lifestyle. It's really not the case. It actually has to go hand in hand. The best success are going to be the changes that come hand in hand with the GLP-1s. But when you look at the intensive lifestyle trial data over time, we know, that education for patients for diet change is important, but there is always a limitation to the amount of weight loss we can achieve. The power of these GLP-1 receptor agonists is being able to help patients to make the dietary changes that they know that they should be making with this increased appetite control from the hypothalamus, and helping patients to keep those changes and sustain them, and hopefully help us with further cardiovascular disease risk later on.
Now, Danielle, I take a sub-Q PCSK9 inhibitor
Yeah.
because I have an elevated Lp(a), as you know. And I got to be honest, I often forget to take it. Even though my calendar says, take it, I'm so busy like you are. And then I'm like, oh, yeah, I'll take it later. And I forget. But now we have an oral semaglutide, GLP-1 receptor agonist. Talk to us about the results of the SOUL trial. Can we use an oral drug?
Absolutely. So SOUL trial looked at oral semaglutide and essentially found that oral semaglutide reduced CV events in high-risk patients with type 2 diabetes with ASCVD or CKD. So what does this mean? So injectable semaglutide, which is a GLP-1 receptor agonist, reduces cardiovascular events in patients with type 2 diabetes. This has been demonstrated in trials before. However, whether or not the oral form of semaglutide confers the same cardiovascular risk benefit had been uncertain. So SOUL randomized 9,650 participants greater than 50 years old with type 2 diabetes and established coronary artery disease, cerebral vascular disease, symptomatic PAD or CKD, to an oral semaglutide. The maximum approved dose in the trial is 14 milligrams daily versus matching placebo on top of standard care. So the primary outcome was 3-point MACE, which was cardiovascular death, non-fatal MI, and non-fatal stroke. And they found that oral semaglutide was associated with a significant 14% relative reduction in MACE, major adverse cardiovascular events, compared to the placebo. And this was primarily driven by the reduction in non-fatal MI. And what's really important to note here is that the magnitude of MACE reduction, this 14%, this is comparable to injectable GLP-1 receptor agonists, including subcutaneous semaglutide, which was looked at in SUSTAIN 6 trial. And we've, of course, looked at other GLP-1s in REWIND and LEADER, like liraglutide. And so it's just really important to note that, that this is an option now. And serious adverse events were higher in the placebo group, but the GI events were more common, of course, with the semaglutide, which we see as well with the injectable. So, oral semaglutide is the first and only oral GLP-1 receptor agonist with proven cardiovascular benefits, demonstrating a risk reduction comparable to the injectable agent with no new safety signals identified, which I think is really great. So for our patients who prefer an oral agent and they don't want to do a weekly injectable, I think this is a phenomenal option.
Now, another trial called STRIDE looked at semaglutide in improving walk distance and how far you can walk without pain. PAD is a bad disease. I mean, very morbid, very mortal. What were your thoughts?
And I think something really important about STRIDE that I thought was really great. Sometimes we just focus on major heart outcomes, such as like heart attack, stroke, major adverse cardiovascular events. And in our day to day with our patients, when we are seeing patients, quality of life is one of the most important things on earth. I have patients who say to me, I don't care how long I live, I want to live well. I want to be able to go to my grandchild's soccer game and walk around the soccer field. And this trial was exciting for that reason. So STRIDE looked at patients with peripheral artery disease in combination with type 2 diabetes, because these individuals who suffer from functional limitations and limited treatment. So GLP-1 medications have demonstrated benefits that may target the pathobiology of PAD. So in STRIDE, semaglutide 2.4 milligrams, the subcutaneous once weekly injected dose, the dose approved for weight loss, this was compared with placebo in 792 patients with type 2 diabetes and early symptomatic PAD. And they found that the semaglutide was associated with a significant improvement in just 12 months with regards to maximum walking distance. This one was really interesting. Pain-free walking distance, the improvement was noted actually as early as 3 months and sustained at 12 months. quality of life improvements, ankle brachial index, and disease progression. So overall, a major win for patients with PAD.
You hit it on the head at the beginning, Danielle, when you said people not only want to add years to their life, they also want to add life to those years. So again,
Well said.
getting around, moving around, is very important to people and also good for them, right? I mean, helping with all these other problems.
Absolutely.
So the other one I wanted to talk about was, a funny name, EKSTROM, looking at the ability of colchicine to improve your arteries, make them look prettier on an angiogram or ultrasound. What did you think of that?
Yeah, so Ekstrom trial randomized 84 patients with coronary atherosclerosis to colchicine, zero point 0.5 milligrams or placebo. The baseline CT coronary angiograms were compared with a follow-up CT coronary angiogram at 1 year. The primary endpoint was a change in low attenuation plaque volume, and the secondary endpoint included changes in total plaque volume and other plaque characteristics.
Now, that low attenuation, that's the fatty stuff, right?
Right, right. And so even though there was no significant difference in the rate of change of the low attenuation plaque, the colchicine was associated with a significant 1.1% reduction in total plaque volume progression and also significantly slowed dense calcium progression at 1 year. And you know what? Another really interesting finding from this study, which I'm sure you saw, was that colchicine's effect on inflammation. So it actually significantly lowered CRP levels independent of baseline CRP values as well.
This is interesting. I mean, some of us have more calcium because we took statins.
Right.
You wonder if this would have minimized that. Do you know if it caused regression or did it just, reduce the rate of progression? Do we know that?
I
I think it was
believe,
just reduce the rate of getting worse, right?
yeah, I think it was reducing the rate of progression.
But
Um,
no real plaque removal.
So
That
I think there were promising trends towards regression in non-calcified plaque, and this actually included the fibrous and fibrofatty plaque types,
I see.
but it was a trend, and I don't believe it was uh
Really significant. Yeah,
yeah,
got
significant.
it.
Yeah.
Now, the final study, Warrior, I was so hopeful. I mean, I can't tell you how many women come through the cath lab with chest pain, and we don't really find anything there. And then the fellow always says, "Oh, another false positive," and I'm like, "No, no, no, it wasn't a false positive. They likely have microvascular dysfunction." So this was a trial to see, can we improve outcomes? So talk to us about it.
I think we were all so hopeful for Warrior, and so the results were interesting and kind of surprising. For me too. I think that my own bias, I was hoping for a really out of the park positive result. But the Warrior trial, this is a really important study. They looked at approximately 2,500 women with signs and symptoms of ischemia without obstructive coronary artery disease, as you mentioned, called INOCA. So they were randomized to receive intensive medical therapy for coronary artery disease versus continued usual care. And at 5 years, which is quite a long follow up, there was found to be no significant difference in the rate of first occurrence of major adverse cardiac events between the intensive medical therapy and the control arms, which really did take me by surprise, to be quite
Yeah,
honest.
me too. I was really surprised. Do you know any more details? I mean, did they do a multiple event analysis, burden of disease analysis? Was anything positive? Any subgroups positive? I don't
Uh,
know.
I cannot remember off the top of my head about the subgroups, but I will definitely look into that.
Yeah, let's look into that because it's so counterintuitive. I was hoping something would, hit it out of the park there. But, do you think microvascular dysfunction, I bet it's a little bit like cancer, right? I bet it's probably a lot of different diseases. And that's why I wonder, is there a sweet spot somewhere in there where we can make a difference? I don't know.
What's so interesting about cardiology that I say to my patients frequently is that, being a newer cardiologist and just having finished training a few years ago, even over the last, since I started med school in 2010, I've seen so many new developments in cardiovascular disease, especially in preventive cardiology and how we manage and diagnose and how things change. And for as much as we think, oftentimes I feel like in cardiology, I feel like compared to some of our colleagues in oncology or in rheumatology or other specialties, sometimes I feel like we're so spoiled because we have so much data and we also have a really good, I think, handle on a lot of the underlying pathophysiology and mechanisms which cause, a lot of the heart disease we see. That being said, things like ANOCA and certain areas of cardiology, I think there's still so much unknown. There's so much unknown. There's so much we haven't quite figured out yet. And I think being comfortable with kind of having that conversation with patients, this is an area where we don't have an answer quite yet. And being comfortable with uncertainty, I think, is humbling, but also important and also exciting because I think we do have pathways forward to get more answers to these questions.
I kind of made a big deal of the microvasculature back almost 25, 30 years ago. And we went through a time where we really tried to treat it in the cath lab and nothing really worked, to really improve outcomes. And what happens is when you don't have an effective treatment, people begin to doubt that or they begin to act like it's not a problem.
Right,
And I don't want to see that happen here. This is
right,
a real problem. And so I'm glad we've at least made the step of recognizing it as a
mhm,
disorder, as a disease. Let's not give up on finding the right treatment for the right patient. I suspect there's a lot of heterogeneity in the pathophysiology.
right.
I think we just got to figure it out. But, it's a good step forward that we now have the science and endpoints to begin looking at this.
Right. And like you said, too, even with understanding the underlying pathophysiology, I feel like, who knows, in the next few years, we may find that there's certain other components of inflammation or certain targets that we didn't realize before could be effective. Who knows? Maybe GLP-1s will be
Right,
effective in this space.
right.
I think that we're really lucky in cardiology because we have just a tremendous amount of, movement and momentum moving forward. And I think especially thanks to people like Martha Gulati and other women cardiologists who really champion women's heart health, and you, Dr. Gibson, who is the best he for she out there, who are championing for women's heart health. I think that, the way that this will continue to make stride, I think is important.
Yeah, I just hope we don't give up. And we just gotta stay on target, keep advocating for this, and keep trying to find solutions. Wow. Wow, that was great, Danielle. Thanks for joining me for this week in obesity. I want to have you back on. You're my go-to person for all things obese, all things prevention, all things nutrition. Thanks for joining us from LA, and thanks to all of you for joining us here.